Hello friends, in today's class we will discuss pseudoexfoliation syndrome. So what is this pseudoexfoliation and what is actual true exfoliation, the pathogenesis of formation and the ocular systemic sources of this exfoliation, the histology and signs which we can see. So coming to what is pseudoexfoliation syndrome. So pseudoexfoliation syndrome is the most common identifiable cause of open angle glaucoma worldwide. So it is a systemic disorder with ocular manifestations that is glaucoma plus cataract with zonular instability. So this is the triad of PXF, that is glaucoma, cataract and zonular instability. Now coming to what is true exfoliation. And what is pseudoexfoliation? So this true exfoliation is nothing but exfoliation of lens capsule or capsular delamination. So it becomes into two parts like anterior and posterior. So this in this what's happening is that superficial layers of the lens capsule they separate from the deep layers and form scroll like margins. And they can occasionally float in the AC as thin clear membranes. So it is also called as glass blowers, cataract. So here there is extended exposure to infrared radiation. It is also seen after trauma or intraocular inflammation and idiopathic. But there is no glaucoma here. So that is true exfoliation. So if we take the diagram of this, to consider these elements. So this is the layers of the anterior capsule which are separated. Okay. Now coming to pseudo exfoliation. So this is a false exfoliation. So here what is there? So there is some material which is being deposited into the over the lens capsule. Okay. And it can be divided into various zones. So in the central part there is a translucent zone. Then there is a clear zone. So this clear zone is in contact with the moving iris. Then is the peripheral, granular zone, which has radial striations. So this pseudo exfoliation is also called senile, uveal exfoliation, iridociliary exfoliation, or pseudo exfoliation. So this pseudo exfoliation syndrome, that is the systemic one, along with glaucoma, is called as pseudo exfoliation glaucoma or glaucoma capsulare or capsular glaucoma. So the prevalence of this increases with age, and it's most common in age above 60 to 70 years. It can be either unilateral or bilateral, and 40% of patients with pseudo exfoliation syndrome develop glaucoma. So this pseudo exfoliation deposits are not only seen just in the lens as we have seen in the figure, it is also seen in cornea. In cornea we have flakes of material which are there at the endothelium. It can also be seen over the zonules and the ciliary body. So here what happens is that the pseudo exfoliated material is detected earliest at the ciliary processes and zonules. So this from there what happens is that there is proteolytic enzymes in this material which causes zonulolysis. So this will cause zonulopathy and trabeculopathy, so that means there are deposits even in the endotrabecular and exotrabecular origins also. And in the iris it will cause iridopathy, in this there are peripupillary, illumination defects. This is due to loss of sphincter muscles, and due to this the loss of sphincter muscle there is improper dilatation of the muscles, and there is loss of pigment in near the pupillary ruff which causes moth-eaten appearance. Due to loss of pigment, and pseudo exfoliation material can also be seen at the pupillary border. So this is called as fnock. So we must remember this because it differentiates from pigmentary glaucoma clinically. So in pigmentary glaucoma we have read it causes mid-peripheral transillumination defects, whereas here it is causing peripupillary transillumination defects and moth-eaten appearance and fnock. So remember this. So here on gonioscopy we can find more pigmentation or which is present inferiorly, most commonly of the trabecular meshwork, and variegated distribution of pigments and flecks of PXF over the trabecular meshwork, and they can be accumulation of pigment at shell baseline or anterior to it. This is called as sampolesi line. Okay, now coming to pathogenesis of this pseudoexfoliation material. So these are actually microfilaments. Okay, so there is a hypothesis of this pathogenesis is plastic microfilament hypothesis. So they have considered this because there are LOX1 gene mutations which are found in this category of patients in some, and on immunoelectron microscopy it is positive for elastin and tropoelastin. So this PXF material is positive for elastin and tropoelastin. Positive, so this is 10 to 12 nanometer fibrils which are arranged like a Christmas tree pattern. So these are this material is not just seen in the eye, but it is called a syndrome because they are produced by many cell types, right? So what are the other cell types we can see? So it is also, that's why called as inherited microfibrillolathy. Okay, so these are also found in other systemic locations like lungs, heart, liver, kidneys, gallbladder, and meninges. So this is the pathogenesis. Coming to how this is leading to a increase in the IOP. So pathogenesis of glaucoma. So they can be genetic, as we said, LOX1 gene mutation, and some environmental factors, some viral causes, and due to trauma, or immunologic causes. So all this will lead to oxidative stress and cellular stress. So this will activate TGF beta 1. This upon activation, what it will do is that we should also have a faulty DNA repair mechanism along with protein misfolding and aggregation, leading to increased elastic component production and increase TIMP 1 and 2, that is tissue inhibitors of matrix metalloprotease. So what this will do, it will increase matrix synthesis and this will reduce matrix degeneration, in turn leading to matrix accumulation so that is so this is extracellular matrix, right? Extracellular matrix, so it will thus cause the reduction in the outflow, causing increased IOP. So this is the mechanism. So main uh, factor here is TGF beta 1 activation. In the next class, we will discuss the course of glaucoma, the DDs, and the management of glaucoma and cataract in pseudoexfoliation syndrome, because cataracts here are difficult to manage. Thank you.